Hi, Dr. Gulani. So it's Wednesday. Just finished seeing patients that arrived today, and some more still landing from all over the world. And some of you asked me to share with you what kind of cases these are. It's my pleasure always. So our team has put together some of these images of the patients that have arrived, and I'll share with you a few things about the principles. Remember, to me, every surgery is a refractive surgery. So even though the cases I'm showing you all these are refractive surgery complications of LASIK, SMILE, PRK, PTK, cross-linking, cataract surgery complications, keratoconus surgical complications, including CARES, CTACs, DALK and corneal transplant complications and side effects and poor vision, patients with collagen cross-linking complexities, and even ALK, automated lamellar keratoplasty complication, hexagonal keratotomy problems. So all these are refractive surgeries. And what I want to stress is I don't want any of you to plan a therapeutic concept. In fact, don't call them therapeutic. Once you call your approach therapeutic, you're decreasing your desire to deliver, and the patient's expectations both are being lowered. All right, so follow my principles. I want you to be planning along with me. I'll be planning for a couple of hours, but you can plan at your own rhythm, and then I'll share with you later what surgeries I do for them. So here we go. Let's go with the first case. That's the case of an ALK ectasia, automated lamellar keratoplasty, which was done a decade ago, and the patient has severe ectasia, and you can see right there the cornea with 9.2 diopters of regular astigmatism, thinned out with ectasia. And what would you do, doctor? Here's the second eye of this patient, similar ALK ectasia. We put intacts, corneoplastic base intacts. You can see sutureless, no stitches in this patient, and he has traveled back to fix this eye at stage 2. So again, doctors, you see my concept, no transplant, how we are constantly improving the vision with least interventional surgery to aim for vision, and that too without glasses and contacts if we can. All right, that's principle will stay with throughout my planning concept for these patients. Remember, think refractive. Don't ever think therapeutic or that you can do any surgical acrobatics that leaves them with less than optimal vision. Now, this case, corneal scar, dense corneal scar, again, think without thinking transplant. Here's a patient with a CTAC done for keratoconus, and you can see the resultant, the surgery is done right there. You see this CTAC segment right here for keratoconus. And if you look here, you can see the topography, 14 diopters of irregular astigmatism, doctor, 14 diopters. What will you do? Here's a DALK patient who had a deep anterior lamellar keratoplasty abroad. Has come back with 6.5 diopter astigmatism, very poor vision, frustrated. What will you do? Patient with spiral hexagonal keratotomy. Remember, this surgery was done opposite to radial keratotomy. Radial keratotomy was done for nearsightedness, and hexagonal was being done for farsightedness and created a lot of instability. What would you do for this patient? Patient with camera. Patient had a camera done for his presbyopia or reading vision, and then had cataract surgery and now left with severe glare, halos, and double vision. He's also had LASIK surgery, very frustrated. What would you do, doctor? Patient with corneal scar, you can see here, with keratoconus, very advanced in this patient, down to less than 200 microns. What will you do, doctor? Here you can see keratoconus, very, very thinned out. You can see the ectasia in this area, full thickness corneal scar right here. A very young man, what will you do? You see over here another keratoconus case, 8.3 diopters irregular astigmatism, 8.3, cornea down to 200 microns, 201 microns. Thinnest local is 194, normal is over 500. What will you do? Patient with multifocal lens, trifocal lens in this case, and YAG capsulotomy done. Patient had gone in for a premium cataract surgery, was pre-op vision was nearly 20/20, frustrated, very troubled with vision. What will you do? And remember, doctor, changing that lens is not an option. All right, what will you do? Patient with penetrating transplant. You can see the transplant done here. This is the corneal graft complete here. All right, patient with very high regular astigmatism, cannot see well through this eye. Graft is clear, but vision is poor. What will you do? Patient with radial keratotomy, doctor, radial keratotomy, LASIK, PRK, PTK done on this patient. What will you do? Young gentleman with the cuts here. 16 cuts, not that much, but severe irregularity in the cornea with the multiple surgeries done in this patient. Patient with a smile complication had smile surgery in both his eyes over here, and smile ectasia. So, doctor, smile surgery can have ectasia. What will you do? And remember again, no transplant allowed. Nothing barbaric. I want vision and without glasses. So these are some of the cases among multiple images. We have videos, as you know, over here for visiting doctors or for doctors who are watching all the time. And again, doctors, remember my principle. Think refractive, think vision. I do not want surgical acrobatics. I want surgical artistry. Least interventional, brief, topical, with numbing drops, no stitches. And I want the patients to enjoy their experience and their vision despite going to the other end of vision and losing hope. So fight for them. So you have quite a few cases here. We have about triple these number of cases with the patients who arrive, but I just want to give you a brief narrative on some examples so you can start thinking, all of you, and use your brilliant minds of what you would do. And again, remember my goals. Aim for vision without glasses and contact, despite this height of extreme complications. All right? If you don't land there, all right, but at least I want to make sure you try it. This will avoid you from doing any surgical acrobatics, invasive surgeries that don't lead patients to real vision, right? So please do that. I have a couple of hours of planning to do before patients again start landing and my planning mode goes on. And really privileged to see these patients who come with so much hope. Their surgeons who refer them with so much faith and the travels that they go through from all over the planet to come to me. So guys, I hope this intrigues you, inspires you, ignites you. For you, Dr. Gulani, I'll be here till late tonight and then see you guys again tomorrow. Take care.